Good morning. I want to thank everyone for joining us today for our bi-monthly Learning Network webinar. We truly appreciate your support for the Florida Association of ACOs and appreciate all the involvement we have had from our members and business partners submitting topics for discussion and sharing resources and white papers that can benefit all members. That being said, before we get started, I would like to remind you that you are more than welcome to also submit information if you haven't already done so. After this call, you can also submit questions for today's webinar by sending them to me at mrudowitz@FLAACOs.com. This information is listed under the Important Information tab on the right-hand side of your screen. Also, before we get started, let me help you with some other resources that you will find on your screen today. In the bottom right-hand corner, you will find links to our FLAACOs resources online. This includes our website at www.flaacos.com. That's FLAACOS.com. There you will find information also about our business partner program, some of our upcoming webinars, and our fall conference. Also, please make sure, if you're not already signed up for our weekly news, that you add yourself to our mailing list and connect to us on our social media outlets, including our Google blog, Facebook, and LinkedIn. In addition to those resources, we have just added a YouTube channel. Following today's presentation, the presentation will be added to the YouTube channel, and you can go back and watch the recording and or share this with members of your team. And the last thing I want to discuss before we get started is in the bottom left-hand corner of your screen, you see register for the FLAACOs Fall Conference. Again, please do not delay and register today. Our conference is just only a few weeks away, and we still have some space available. It's filling up rather fast, and I'm sure that if you haven't already signed up, you will want to attend. Please go to our website at FLAACOs2014.com for more information. That again is www.FLAACOS2014.com. If you use promo code ACO2014, you can save 20%. This code is only available until the end of August. With that being said, it's time to get started on today's presentation. As promised in past presentations, I promise to keep this to 30 minutes or less. I know your time is important, and I want to make sure that you can gather the information you need and go ahead and move on with the rest of your day. If there is something that I'm not able to answer on this call today, or if you have follow-up questions, again, please contact me directly, and I would be happy to answer your questions and share those with the members of our community. Today's topic is ACO 5-step process for reducing readmissions. Now, as in past presentations, for those of you that are new to our organization, I want to make sure that you understand who we are. We're just going to take the next two slides briefly outlining this again, as we have in the past. FLAACOs is the premier professional organization of ACOs and those ACO organizations throughout the state of Florida. Again, for those of you that may be new to the ACO community, ACOs provide to work together to increase quality of care, deliver to patients while significantly lowering those costs. We have a member group of a network from groups around the state of Florida, as well as now many members nationwide who are joining our organization to share and collaborate on best practices for ACOs. That being said, if there is a resource that you need, whether you are new to an ACO or thinking about joining an ACO, or possibly even working for an existing one, please contact us and we would be happy to network and provide resources for you to other members in our community that can help you move forward, improve outcomes, and reduce costs. our website at FLAACOs.com, there's detailed information about our leadership team, our founding members, and some of the ways that you can get involved, both as a business partner and by participating on one of our committees. We really extend this opportunity for you to not only provide exposure for your organization, but also to really benefit from the resources that are available within the communities. So when we talk about today's topic, the first and foremost thing, for those of you that may be new to what were the purposes of reducing readmissions, I thought we would give just a little history that back in 2010, as part of the Affordable Care Act, and again, it implemented in 2012, hospitalizations around the country really were at an overall high in cost, impacting over $2 trillion spent on healthcare in the United States. And when we look at these costs, a good portion of them, about $15 billion annually, was spent specifically for people that are leaving the hospital and readmitted shortly after, within a 30-day time period. So a reduction program was created really to cause a penalty, per se, for certain care areas that are measured to really try to improve the total outcomes for care. Initially, there was a 1% penalty. Then the next year, it was a 2% penalty. And now, starting this October of 2015, which is, coming up right here, the maximum penalty is going to be 3%. So as we raise the bar for how much the penalty is for improving that care, we're really also giving a guideline on those measures that we want people to work on. CMS has also decided that instead of there being 3 measures that were in the past used to, again, rate readmissions, and those were specifically for pneumonia and heart attack and heart failure, now, new for 2015, they'll also be looking at hip and knee replacement, along with chronic obstructive pulmonary disease. When we look at these different reasons, as the quality benchmarks have just changed as well for ACOs this past month, and we've looked at all these new measures that have been put into place, we now see a trend as well where the readmissions and the reduction extending beyond those initial 3 areas to 5. Again, the whole idea is to improve the outcomes of our patients that are participating both in our ACOs and across the healthcare reform industry. And by doing this, hospital readmissions is one of those areas that we have to pay close attention to. When we look at some of these influencing factors that are really impacting that readmission rate, when we talked generally, just on the last slide, about the 30-day readmission rates, I mentioned the heart attack, the heart failure, pneumonia. But when we look at some of these other things, there's a lot of influencing factors that also play into why someone may be readmitted. And as we look at how we are building and developing networks for improving care coordination, we look at all these different things and all these different groups and how we can impact them both as an individual physician, as an ACO, and as a healthcare community. For example, high percentages of residents that are Medicare beneficiaries or may have been unemployed or who haven't been married may be higher with hospital readmissions. Typically, retirement destinations where there's a larger group of individuals with more extended money, a higher socioeconomic status, those communities typically will have a lower rate because, again, they're being more preventative in their care coordination. Typically, if you see a higher number of general practitioners and primary carers, if someone is participating and using a primary care on a regular basis, the intent is to lower readmissions through preventative care. However, if there's a large number statistically of specialists in an area, it oftentimes will lead to higher readmission rates. And so when we look at these, and while I'm talking about them in generalizations, we also have to understand that there are ways that we can use this data and these tools to then tailor our approach for specific audiences and to really combat the issue that we have with readmission. Now, again, and these are just a few more things that we need to take into consideration when we look at factors impacting readmission. Some of the things that we need to do is we need to understand the patient's functional ability to understand what's going on around them. We're quick to label patients as non-compliant when maybe they really need help understanding the knowledge and the skills of patient self-care. So the education process, which is, again, a big component as an ACO, and working with the primary cares and working with the specialists and trying to coordinate that care is a big part to make sure that there is success and that there is less readmissions. Also, when we look at compilation of medical records, when we look at pharmacy records, when we look at what patients are on and what they're not, that care coordination is a big piece in making sure that a record is not incomplete and that errors can be acknowledged and addressed in a timely manner. So we've broken this up into 5 easy steps for individuals to understand how an ACO really can influence reducing those readmission rates. The first and foremost, as we have had with our ACOs, is step 1, care coordination. Your primary care physician, also known as the PCP, is the core team member. Enhanced primary care and behavioral health and care coordination is vital for the success of lowering and reducing those readmission rates. This includes preventative care, everything from reminder calls, having a team approach, integrating different specialties like behavioral health and physical health, where one person can be really the advocate for that person. And that person extends to not only the doctor and the physicians and the nursing team, but also support groups and education programs within the community. One of the advantages that we have realized working within an ACO background is that non-clinician team members, home visits, different staff, call centers, and all those extended services do extend that care coordination of the primary care physician. So the first and foremost is to have a point of contact for all the care for one person. We talk about the next step. We talk about step 2, which is patient engagement. Patients can reduce their chances of being readmitted and being engaged. And you ask, well, how can you do this? Well, you can do this by informing your doctor of all of your medical conditions. By full disclosure, what are you taking that's a prescription? What are you taking over the counter? By scheduling follow-up visits and actually going to your follow-up visits. Oftentimes, when we look at certain segments and populations that are readmitted, one of the big things is transportation to and from those visits. And making sure that there is a line of communication between a plan, well, if they have insurance, what's accepted, what's not. And if it's not accepted, how do we go about planning and continuing that care? If they don't have insurance, again, it's how are we going to pay for these doctor's visits? And that's part of that patient engagement in the process. The more involved the patient is in the process, the more likely we are to have less readmissions. We're going to move on. The next step in our process is include extended family and caregivers. This goes beyond just family and caregivers. This says include the community. Your network is every single person that has an impact to truly embrace and enhance the care for that individual. So when we look at involving the patient, their family, the family caregivers, and community providers, these are all full partners in the needs assessment of a patient's homegoing needs. And when we look at this, they all need to be part of the process and assessed when we look at post-hospital needs of all hospitalized patients. And again, if they don't have a family or these things, who are the extended resources in the community that we can depend on? And I think one of the benefits of working with an ACO community and working with the extended different groups that are really working together to improve care coordination, it's having those voices work together and those resources collaborate to be able to extend that care to those patients when they need it most. A lot of times also is the teaching and facilitating of learning. And that goes for not only the patient, but the extended family, the caregivers, and every person involved. You know, in the past, it may have been where a person went to the doctor, they didn't understand what was being said. Now more than ever, it's focused on that customer service piece. It's making sure that we're asking open-ended questions of our patients so that we can get true answers of how they're feeling and what they understand and what they don't. It's making sure that our patients are educated. And a lot of times this is really simplifying it down, making easy to read written materials, focusing on what patients need to know, and really making sure that everything is at a point that all the different stakeholders can be involved. It's not just something where one person's the point of contact. Everyone has to be on the team together. Now, when we look at step 4, as important as it is to have the right primary care and a point of contact for a doctor and patient engagement and a team, if you don't ask the right questions, we're not going to get the right answers. So when we look at this, we need to be able to ask some significant questions like, where's the patient going to go after discharge? Who'll be providing the care? Is it going to be adequate? Do we need more care? Do we need to contact other resources? What are the patient's needs after discharge? And what are the discharge barriers? What's the problems that could be in place that could be included part of this condition or could be from a separate outlying condition that may make it hard for this person to be discharged? Also, length of stay is a key role too. If it's too long, there's possible reinfection, but if it's too short, we have issues where maybe they're not getting adequate care. Lots of different questions we have to ask. And why we ask these questions? Well, we want to make sure that patients have an underlying health condition that is being treated, that if there's a condition that wasn't treated, that we know about it, that we want to make sure that if there's a complication after discharge, the patient and the community and the team know what to do. What are the steps that we need to do? What do we need to look for? And we want to make sure that the doctor's instructions are truly being followed. The intent that primary care, those doctors that are working all together and coordinating that care with a specific timeline and plan for each customer and each patient to know what to do when. Step 5 in the process is post-hospital follow-up care. When we look at this, this is probably one of our biggest opportunities to address these conditions of rehospitalization and to prepare those patient and family caregivers on what the next steps are in the process. So, what do we need to do? Well, we need to have real-time critical information on what needs to be done to that primary care doctor and to that clinical team. So everyone needs to be included in the communication process. And that's talking about what we do in ACOs as far as integrating data and making sure that that information is available in real time. Again, it may be including different home visits, increased clinical follow-up, possibly more visits to a specialist or to therapy. In order to reduce those readmissions, it's not that everyone will have the same discharge plan. It's really customizing those based on the questions that we've asked and the team and all the answers that we received. And the social risk for readmission, like we talked about on the first slide when we talked about influencing factors, based on income level, outside influences, being married, based on socioeconomic status, those do play a role in that post-hospital follow-up because it depends on whether they have access to care without resources. So it goes back to the importance of that team, of developing a plan, so that there's no question that there's transportation to get them to follow-up visits. So there's no question that insurance or non-insurance is going to pay for the medication. We want to make sure, again, that that follow-up care treatment is not just something that you give them when they leave, but that truly is an extended part of the process of their visit to reduce the chance of them coming back. And when we talk about those handover communications, we need to make sure that what the hospital is delivering is consistent, concise with what has been discussed. So real-time critical information. And this is really how we're able to leverage what is being done in a hospital setting or with a specialist setting with what's being done right now on a level with our primary care physicians and with the doctors and specialists that we're working with in our ACO communities. Now, this is a topic that we could discuss for a very long time. Very passionate about the impact of this because at least one of us, if not us as an individual ourselves, have experienced something where we know someone who's been readmitted or has been readmitted back ourselves. And how we move forward with trying to not only impact the cost on healthcare, but also improve the outcomes and the overall process is something that we can all work together. I encourage you to contact me directly with any questions or feedback. I also welcome the opportunity. If you would like to share other resources on this topic, we will gladly include them on our website, on our weekly emails, and through our social network. Please send resources. We would love to share this with our community. Thank you for joining us today. As promised, we needed to keep it under 30 minutes, and I think we have about 2 minutes left before I run over. Please remember to go to the website, FLAACOs2014.com, as located in the left-hand side of your screen, and sign up for our conference. There are different levels for ACO members, for non-members, and for students. Please don't delay. Sign up. We really would love to have your participation and collaboration at this upcoming event. That being said, thank you and have a wonderful afternoon.